Today you will learn about border molding and how to take an amazing secondary impression. Hi, I'm Yichi from MDSA's Academic and Research Committee, and this is our expert for today, Prof. Prashanti.
Hello all.
Yes, and welcome to Season 3 of Bite-Sized Learning, which is MDSA's series of clinical videos that help you and I and answers commonly asked questions in dentistry. Now, as always with BSL, we'll have a little bit of a chat with our expert first about the topic before we go into the live patient demo part, which is the juicy and the practical part of it. I have here a list of Prof. Prashanti's academic background to share with you, and it is by no means short, it is quite extensive. So please bear with me while I go through it. Professor Dr. Prashanti Eachempati is the Professor and Head of Department of Prosthodontics at Manipal University College, Malaysia. She is also Deputy Dean and Coordinator of Research and Elective Projects. She has a total of 8 qualifications and fellowships and 1 ongoing PhD. She has 30 research awards, 82 publications in prosthodontics, medical education and Cochrane systematic reviews. She has multiple research grants, has 41 workshops conducted or is a guest speaker at those workshops. She even has an intellectual property, I think registered in India, for a soft palatal gauge. And above all, she is an amazing teacher, a great scientist, and an incredibly clear thinker.
Thank you, Ichi. And I think this is a fantastic initiative, bite-sized learning by MDSA. And I'm extremely delighted to be part of this. And thank you for inviting me.
So today's topic is about border molding and secondary impression taking. So which begs the question, what is border molding and what is secondary impression?
Alright, before I answer that question, I would like to show you the edentulous mouth and the denture bearing areas. I always believe that prosthodontics is very difficult to imagine. So let us have a look at this picture to understand what do we mean by the denture bearing areas. So as you can see here, we have the dotted line which is representing the peripheral structures or what we call as the limiting structures. It is the vestibule, the freni, which are called as the limiting structures. Then we have the supporting areas, which could be the primary or the secondary stress bearing areas, and also we have the relief areas which need to be relieved. Similarly, we have the same situation in your mandibular arch where we have the limiting structures, the supporting structures with the primary and secondary stress bearing areas, and also the relief areas. Now that we understand the different types of the denture bearing areas which are available in an edentulous arch, we can define border molding. So border molding is to shape the borders of an impression tray by using any kind of a material like a low fusing compound, for example, or elastomers, so that we can contour the shape and size of the vestibule, and this will allow us to create a peripheral seal so that it will aid in the denture retention. Now when you talk about secondary impression, we need to differentiate it between the primary and the secondary. Primary impression, as we all know, allows us to prepare a diagnostic cast, or it is a preliminary cast, and on which you can actually do your treatment planning. But a secondary impression, on the other hand, allows us to fabricate a master cast, and this master cast is the basis on which the denture is fabricated.
Thank you. And I've always had this question, but I've always been afraid to ask it, which is, if I've already done a wonderful primary impression, why is there still a need to do border molding and secondary impression?
Of course, it is not just you, but many clinicians have this query in mind, why secondary impression when we have a very good primary impression? I would again like to direct your focus onto the fundamentals. Have a look at this picture to differentiate between the different stress-bearing areas of the edentulous mouth. Based on the mucosa, the submucosa, the bone underlying, and also the underlying structures and direction of forces and muscle attachments, the denture-bearing area is divided into primary, secondary stress-bearing areas and also the relief areas. Now, If you see this particular maxillary arch, we can say the crest of the ridge, very well formed ridge. So crest of the ridge as well as the horizontal portions of the hard palate I can use as the primary stress bearing areas, the rugae and the maxillary tuberosity and the slopes as the secondary stress bearing areas, and of course the incisive papilla and the mid palatine raphe as the relief areas. Similarly, in the mandibular arch, you can see that the crest of the ridge is well formed. So along with the buccal shelf area, the crest of the posterior alveolar ridge can be used as a primary stress bearing area. Anterior crest could be a secondary stress bearing area, and so on and so forth. Now let us have a look at the next picture, which is going to show you a different ridge characteristic. So the mandibular arch, as you can see here, is extremely resolved. Now in this case, the primary stress bearing area is only the buccal shelf, and the crest cannot be used as a stress bearing area at all. And you can see the maxillary arch where you are having the flabby tissue in the anterior maxillary arch, and that will act as a relief area. So differentiating these different types of tissues in the oral cavity is extremely important, and just by making a primary impression, this differentiation is not possible. The unique feature of a secondary impression is the fabrication of a custom tray or a special tray, or we can also call it as an individualized tray. And based on the different types and designs of the spacers, we can actually control the pressure which we are placing onto this denture bearing area. We can have the differential loading of the primary, secondary stress bearing areas, and also relieve the relief areas. So that is the unique feature of a secondary impression. And most important thing we need to remember is the principles of impression making. It is preservation of the residual alveolar ridge and the surrounding tissues, retention, stability and support, and of course which all will enable us to achieve the aesthetics. Now all these principles can be achieved only when we have the understanding of the denture bearing area, its different characteristics, and how we are able to differentiate that in making of the secondary impression. And that's really pertinent for any clinician if you want long-term prognosis of your complete denture for the patients.
And a bit on the technical side, what materials would you recommend for border molding and secondary impression taking?
So when we talk about materials for border molding, it depends on what type of border molding. Is it a one-step border molding, or is it a sectional or an incremental border molding? Because for a one-step border molding, you could use the elastomers as you can see in this picture. And for a sectional or an incremental method, we will be using a low fusing compound, as you can see here, also called as the green stick compound very commonly. Now when we talk about secondary impression materials, we have most commonly the zinc oxide eugenol impression material and also the elastomers, which are most commonly used. But if you would ask me what is the best, I wouldn't be able to justify and say, because as far as evidence base is concerned, if you look at the Cochrane systematic review, none of the materials or none of the techniques have been shown to be superior when compared to each other, and because of the low quality of evidence, we wouldn't be able to say so. But depending on the rich characteristics, a clinician needs to choose the appropriate material as well as the technique. For example, if there is an undercut area, you would not be able to use a zinc oxide eugenol, and you would need to use elastomers and so on and so forth. So that is up to the clinician to decipher the appropriate technique as well as the appropriate materials.
Interesting. And my final question would be that as students, what are the common mistakes that we do, and what are the precautions that we should take before, during and after the secondary impression taking?
Alright, what I feel is most commonly students neglect understanding the edentulous area of or the denture bearing area of the patient. So it is important and mandatory for us to study your anatomical landmarks present in that particular patient before you even start off with your impression, because that determines what type of impression technique you would want to use or what type of materials you would want to use. So studying the anatomical landmarks, looking at your supporting structures, looking at primary, secondary stress bearing areas, and what are the musculature which are surrounding this edentulous ridge is extremely important and pertinent. So that is the first stage to begin with, that is before the impression. Study your primary or the diagnostic cast, study the patient's edentulous ridges. Now during the impression making, I would classify it as the 3 M's. The moulding, that means functional manipulation of the tissues, is something you really need to look into. Second is the method, which type of impression technique, what would be the spacer design? Are you going to use a selective pressure where you are selectively going to load the tissues, or are you going to use a mucostatic impression where all the tissues will be relieved? So these are the decisions which you need to make. And finally, the material of choice. Depending on whether there are undercuts, what is the type of the tissue, we need to select the appropriate material for the independent case. So these are the different areas you need to look into during the impression making. Now after the impressions, many a times you are not reading your impressions. This is extremely mandatory, looking at whether any areas are overextended, whether there are any underextensions in your border molding and the final impression, and looking at any kind of lacunae or errors in the impression is of utmost importance to decide whether you need to repeat the secondary impression or you can move on. Not only that, you also need to ensure whether the retention, stability and support have been achieved as you have planned for the patient. So these are the things I think are the tips which you should follow for making good secondary impressions, and which is preceded of course by your border molding.
Yes, thank you, Prof. Prashanti. And that wraps up our chat before our live patient demo, which is the next section, so stay tuned.
Today we will be learning about maxillary border molding. So as you can see here, the special tray is ready. After we have made the primary impression and the diagnostic cast, we fabricated the special tray with 2 mm of borders, but it should also be 2 mm short of the peripheral sulcus. So that is what we need to check in the patient's mouth before we start off with the border molding. So place the tray gently into the patient's mouth and check if the borders of the tray are 2 mm short. You can see here that the frenum relief is sufficient. You can also see that the buccal vestibule there, the peripheral sulcus, is not being contacted by the tray. That means it is 2 mm short of peripheral sulcus. However, in this labial sulcus region, we can see that the tray is contacting the peripheral sulcus. You cannot see the 2 mm of clearance. So that is where we need to trim the tray before we proceed with the border molding. A very important aspect is that the tray needs to be dry before we add the low fusing compound, or else it may not stick to the special tray. So wipe the tray first before you take the low fusing compound. Now hold the low fusing compound in a pen grip so that it is firm in your hand, and we need to heat the material without burning the low fusing compound in the Bunsen burner. We will start off with the labial sulcus recording, so add the material to the labial border of the special tray as shown. If the material is slumping away from the borders, take a little cocoa butter and stabilize the material onto the borders. Temper the material before you place it into the mouth. Gently reflect the tissues and seat the tray without the material touching the tissues until it is seated. Perform the functional movements for recording the labial sulcus. Lift the lip with the thumb and index finger outward, downward and inward. Also perform the buccal movement near the canine region in order to avoid any overextension. Reflect the tissues to check if the frenum is recorded well, and also whether the material is contacting the peripheral borders as shown. You can see that the labial sulcus is well recorded. If any material flows inside the tray, remove it prior to proceeding with the next segment. Now for recording the buccal sulcus, add material to the buccal flange of the special tray. See that the segments do not have any discontinuation. Temper it and take it into the mouth. Reflect the tissues so that the material does not contact the tissues until it is seated into place. Stabilize the tray with 2 fingers, hold at the modiolus and perform the buccal movements. Ask the patient to open and close the mouth and also perform the lateral movements, that is the right and left. This is to record the distobuccal sulcus, which is limited by the movement of the coronoid process. You can check the extensions whether the material is properly extended onto the peripheral sulcus. Repeat the same onto the other side. The functional movements are performed by holding at the modiolus and reflecting the tissues outward, downward and inward. Ask the patient to open and close the mouth and also perform the lateral movements, that is the right and left. Now you can see that both the distobuccal borders have been recorded for the maxillary arch. Place the T-burnition on the crest of the ridge so that the ball end is towards the palate and move posteriorly till there is a dip which is representing the hamular notch. Perform the same on the other side and locate the hamular notch. Mark the hamular notch with a marking pencil as shown. Ask the patient to say "ha" so that you will be able to demarcate the junction of the hard and soft palate. The point marked represents the end of the posterior nasal spine. Connect the hamular notch to the central point and extend the line to the opposite side hamular notch. This line represents the posterior vibrating line. Place the special tray so that you can check the posteriormost extent of the tray. Now to mark the anterior vibrating line, use the ball end of the T-burnisher to palpate the tissues which are more compressible in contrast to the other areas which are non-compressible. Repeat the same on the other side. Transfer the same onto the special tray. Add low fusing compound to the posterior border of the special tray and also onto the anterior vibrating line area which we have transferred from the mouth. Seat the tray into the patient's mouth. Ask the patient to bend the head down and say "ha." Also ask the patient to open the mouth and close. You can see here the typical cupid bow appearance of the posterior palatal seal area. Once the border molding is completed, before making the final impression we need to check for retention, stability and support. Remove the spacer. Make relief holes in the mid-palatine raphe and the incisive papilla region. And also dry the palatal area with a gauze prior to making the impression. Dispense the zinc oxide eugenol base and catalyst paste of equal length. Mix the material homogeneously. And load the tray. Ensure that the borders are evenly covered. Place the tray into the patient's mouth and ensure that the material flows out through the relief holes. Once the flow of the material has stopped, repeat all the functional movements which you have just performed. Check whether the material has set by trying to place an indentation with your fingernail. Check for retention stability and support. You can see the zinc oxide eugenol wash impression here.
Today we will look at mandibular border molding. So the special tray is ready with me after the primary impression and the primary cast are made. I'm going to place it and check whether it is 2 mm short of the peripheral sulcus. Stand in front of the patient and gently place the tray into the mouth. Check whether the borders of the special tray are 2 mm short throughout, that is labially as well as buccally. For checking the lingual extension, ask the patient to move the tongue to the right and left. The tray must not lift. Ensure that the tray is dry before you add the material. Hold the green stick compound in a pen grip and heat without burning the material.
You could start the mandibular border molding either by adding the material on the buccal or the lingual aspect. Here, I am starting from the lingual sulcus by adding the material onto the borders of the lingual flange.
If the material is slumping away, use cocoa butter onto your finger and stabilize it. Temper the material before placing into the mouth. Place the tray without touching the tissues. And a clinical tip is run your finger gently so that the material adapts towards the tissues before you do the tongue movements. Ask the patient to do the right and left tongue movements. Repeat if necessary. You can see here the lingual sulcus of the mandibular arch, the S-shaped curve which is recorded. Repeat the procedure on the other side. You can see that both the lingual sulci are recorded. You can see the contour of the lingual sulcus on both the sides. If any material flows into the tray, remove it prior to proceeding to the next section. Proceed with recording the anterior lingual sulcus by adding the material, tempering it and taking into the patient's mouth. Place it gently into the patient's mouth. Ask the patient to lift the tongue and touch to the anterior portion of the palate. You could also ask him to lick the upper lip as shown. This will enable to record the anterior lingual sulcus and ensure that there is a continuity between the segments which you have added. Now to proceed with the distal and the distobuccal, that is the mesenteric notch area. Add the material, place it gently into the patient's mouth, stabilize the tray, adapt the material, ask the patient to close against resistance. You can see the mesenteric notch recorded. Repeat the procedure onto the other side. Now move on to the buccal aspect. And perform the functional movements. Outward, upward and inward movements holding at the modiolus. Add material onto the anterior border of the tray to record the labial sulcus. If any material is slumping away from the borders, use cocoa butter to stabilize the material onto the tray prior to placing into the mouth. Stabilize the tray with both the fingers as shown. Use the thumb and index finger to perform the labial movements. You can see the labial, the buccal, lingual aspects of the border molding completed. Before proceeding with the final impression, check for retention. Stability and support. This is the completed mandibular border molding. Remove the spacer and place relief holes prior to proceeding with the impression. The relief holes are placed in the anterior mandibular crest, load the material evenly onto the tray. Ensure that the material spreads onto the borders. Seat the tray into the patient's mouth and ensure that the material flows out of the relief holes prior to performing the movements. Perform all the functional movements as described previously. Once the material is set, check for retention, stability and support. We have the completed mandibular impression.